Hello, my name is Susan Cosgrove, and I will be your host for this episode of the live stream show, My Diabetes HQ Live. This weekly broadcast is developed and produced by Cities Changing Diabetes volunteers in Houston and here in Philadelphia, which recently joined the global network of 25 cities working to improve diabetes prevention, care, and management. You can learn more about Cities Changing Diabetes by going to citieschangingdiabetes.org. The purpose of this effort is to help people with diabetes and their caregivers successfully transition through these very challenging times of COVID-19. Every Saturday, we gather diabetes care experts to discuss and to share their incredible knowledge about diabetes. They have years of experience in self-care, medical care, public health, community health, and advocacy, and are bringing this knowledge straight to your waiting eyes and ears. We hope that these conversations will give you the tools to build skills to manage your diabetes and live your best lives, not only surviving, but thriving and doing the things that you love. Today's episode is coming up right now, so stay tuned. You don't want to miss it. The content shared during My Diabetes HQ Live's broadcasts are not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding any medical condition. Good morning, all you diabetes warriors, champions, and advocates. Welcome to our 12th episode of My Diabetes HQ Live. We are joined by My Diabetes HQ Facebook and YouTube channels. Thank you and welcome to our show. We're so happy to have you here with us. Today, we are bringing you another Ask the Doctor question and answer session with a focus on medications. You will hear more about what to do if your medication is recalled, get answers to common questions about medications, learn how to work with your care team to find the right medication for you, and learn how to approach your doctor if things just aren't working. Tell us where you are and leave us a comment or question below. We will try to get to as many questions as we can during our time together. And even if we don't get to your question during this episode, please leave it as a comment. So I'm going to start this morning by introducing our panel. So we are joined yet again by one of our all-star guests, Dr. Ajay Rao, Professor of Medicine at Lewis Katz School of Medicine at Temple University in Philadelphia. Good morning, Dr. Rao.
Good morning. How are you?
Good. And then we're joined by our trusty panel, Maryanne Strobel, registered nurse and certified diabetes care education specialist.
Morning.
Morning, Maryanne. Hello. And then Serena, Valentine, CEO of Core Initiatives and Houston's Diabetes Peer Support Initiatives Program Coordinator. Good morning, Serena.
Good morning.
So I want to get our discussion started today. I think we chose this topic because we know that diabetes self-care can be frustrating. It can really be a lot to manage all of the medications and everything that a person with diabetes has to do to take care of themselves. And I think this was also prompted by something that might be top of mind for many people right now, which is a recent medication recall of a common diabetes medication. So I just want to start by asking our panel, what does a recall mean? And if my medication is recalled, do I need to be worried about my safety and what should I do?
Yeah, I guess I'll take a stab at this one. I mean, I think it's, recently this has been happening a lot more frequently than we'd like it to be for a variety of medications, whether it's agents used in diabetes or otherwise. Usually it really means that the Food and Drug Administration, which is sort of the supervising authority for prescribed medications in this country, has kind of caught something that might be a problem with either and this is a key thing, either the medication itself or the compound that's used to sort of create or produce the tablet or pill or whatever however you're taking the medicine. And it usually means there's an issue, and there's usually a really good understanding as to what your next steps should be in that scenario. Typically working with your pharmacist to find out if what you're taking is affected is usually the way I think of it when I think of the word recall.
Yeah, that's pretty much what I tell my patients too, Dr. Rao. I tell them, first of all, call their pharmacy, call their pharmacist, and then please do get in touch with your physician's office right away and see what's going on. But first thing to do is call that pharmacy.
Mm-hmm.
Yep.
That's great. So really it's going to be the pharmacy and the pharmacist that's going to have the information to know whether the medication that you're taking is one of the ones that's been affected and can then kind of guide you what to do next.
Yeah, because usually the pharmacy will have there's specific numbers, right, that are connected with either the bottles or the brand or that identifies the actual medication or compound or whatever. And I think instead of just sometimes patients are just reactionary. It makes sense, right? You hear something, you get scared, you don't know who's watching this. But luckily the pharmacist can immediately tell you if you say, hey, I got this medicine on such and such day. I heard about this. Is this affected? And they'll know if they haven't reached out to you already.
Yeah, that's great. So don't panic. Call your pharmacist. Call your doctor.
And just to bank off of that, Dr. Rao, one of the things that we've seen in years ago, we've had some issues with recalls on test strips for our glucose meters. So one of the things that we haven't had it, of course, happen in a long, long time, but I do tell my patients that it's so important that they go ahead and register their glucose meter as well, and let the company that makes the glucose meter know that they have this device, just in case there would be, any recalls on anything. So I think it's so important, even with diabetes supplies, that people do get them registered.
That's a great point. We forget about that sometimes, and that can be such a huge deal when you're monitoring and trying to adjust medicines based on the levels.
Yeah.
Great. So I want to move on, I think a lot of people with diabetes, they have questions when they're prescribed a medication, and obviously insulin is a very common medication that's used to treat diabetes. So, what do you do if your doctor tells you that they want you to start taking insulin to control type 2? Does that mean that my type 2 has progressed into something else or has turned into type 1 diabetes? And why can't I take insulin in a pill form instead of the injectable?
Yeah, sorry, I cut out there a little bit, but I think the latter half about the pill form, I think there's a lot of research going into this to be able to get insulin to be produced in a pill form, but unfortunately, it's been riddled with a lot of setbacks. And I think all of the makers who make insulin are really committed to this, but it seems to be a problem with the way it gets processed by your body, by your liver, where you just can't see the same amounts if it was given in a pill form versus an injection. So we're not there yet, but that doesn't mean that there aren't people who are really spending a lot of time looking into this and hoping that there's going to be a better future, hopefully in the near future, when we can take insulin in pill form.
Yeah, and I think the other part of that I've keep having questions from patients, Dr. Rao, is that patients want to know that if they have type 2 diabetes and they've had it for quite a long time, and they were taking pills and suddenly their doctor tells them they need to go on insulin, they ask me, does that mean that their type 2 diabetes turned into type 1 diabetes?
Yeah, I can't tell you, I get that question a lot too. And I think, it sometimes can also lend to some confusion when you're talking to patients for somebody you're meeting for the first time. I think, we typically, if you go back many, many years, used to connect, sort of insulin means you're type 1 because that's a scenario where your body's making little or no insulin. And clearly, there is a great amount of patients who use or need insulin to help even in type 2 diabetes. And I think that it's important to not connect insulin use with any sort of transition from type 2 to type 1, I think is crucial. And I think that's why, we used to have these terms, insulin dependent diabetes, non-insulin dependent diabetes, and I think we were definitely moving away from those. But clearly, if you are on insulin, that just may mean you can still be a person who's living with type 2 diabetes, but it just might mean that you're needing the insulin to help you gain better control. But it doesn't transition you into becoming a type 1 diabetic. And I think when we say type 1, we're really thinking of those who are making little or no insulin.
Mm-hmm. Yeah, I know well, not just in peer support, but people I run across that are dealing with diabetes. I try to tell them, don't think of the diabetes medications as levels of punishment, because a lot of times, people are looking like, and so, but you know what? It's not all the patient's fault, because I've been to doctors where they'll like threaten you with it. Like, well, if you don't do this, you're going to have to take the needle. And it's like, that it sounds like punishment. But see, in my particular situation, my body was not doing well with the pills. So I asked my doctor, this is not working. My body doesn't feel right. I will take insulin. And she just kind of looked at me like, I have never heard this before. Strange patient. Like, she's like, Ms. Valentine, I have never met anyone like you before. They were expert. But because at the time my son was 2 years old and I could barely move around because my body was feeling so bad, I had to do something to change. So I tell people, don't think of it as levels of punishment. It's not punishment. It's just different ways that everybody's body takes medications, So.
Yeah,
I'm sorry.
Go ahead, Maryanne.
Well, I actually tell my patients that not to think of insulin as a medication. I tell my patients to think of insulin as supplemental hormone. And usually when I tell them it's a hormone supplement, they're just very thrilled to take hormone supplements. So I'm happy.
Sounds more natural, right?
Yeah. I mean, I think that even from the provider standpoint, we've been trying to disconnect this sort of penalizing people for being on insulin, right? And I think that's a great point that you bring up, Serena, because I think we, I'll give you an example. I talk about insulin in all patients, so that they understand that might be a place where you have to go or need to go to gain control, and not to connect it with meaning that you failed in some way. And then I think that's really important for the patients to hear and understand.
Dr. Rao, with some of the pills, like the insulin secreting type pills, can you talk a little bit more about that? Because, we know that some of these types of medications that patients may be on for a long time with type 2 diabetes, and then after a certain while, they just don't seem to work anymore. Can you maybe explain a little bit about how that happens?
Yeah, I think, I try to explain this to my patients. Clearly in type 2, we know that your body is making some amount of insulin, but that insulin is, probably not of a good quality or not sufficient enough to get you to your goals. So, luckily, early medications or, the initial medications approved, meaning pill forms in type 2 diabetes, included a class of medications. One of them is called sulfonylureas. And so these medications work by basically forcing your body to make more insulin, essentially. And I think that they definitely work for sure. And we have a long-standing experience with it and history of these medications. But clearly, there sometimes can be connected with the development of a low sugar episode. And so you have to be careful with that. And then we do know that in just, as people age, they may lose their ability to make insulin. That's a common thread for all folks, regardless of their control level. And so, sometimes you wonder whether some of these agents potentially could sort of exhaust that ability of your own body to make insulin. But again, it is something that you have to work with your doctor. So that's one approach, that people have used to figure out with pills. And then the other approach is really sort of making your own insulin work more effectively. And that seems to be kind of the rest of the slew of medications that we have that are available both in pill form and injectable form.
Mm-hmm. Yeah, great points from everyone. And I really love this idea of thinking about medication, removing the stigma from it. So it's not that you've failed, it's not that things are worse. It's really just that you're doing what you need to do to take care of yourself. And that can change over time. It can change over your lifetime. What works for you today might not work for you in a year. And Serena, I think that you are really an expert at this. Could you provide some tips for how you talk to your doctor, how you initiate that conversation if you feel like your medication's not working well for you?
Yes, most definitely. I normally give these tips out to my people, so everyone out there today get to get a snippet. But it's a document I found some years ago called the Patient's Bill of Rights, and a lot of people are not aware that they do have rights. If something's not working for you, you can go and talk to your doctor and tell them, hey, this is not working for me. Or even if the doctor's not working for you, you have a right to go seek medical attention elsewhere. So a couple of things that I could highlight on there. One of the rights on the Patient's Bill of Rights is, like I said, to seek consultation with the physician of their choice. You have a right to choose. Also, you have a right to talk to your physicians and get on a common ground with them. You must agree. You don't have to agree to everything. Things may not be the way that you would like them to be. And if you're not comfortable, most likely you're not going to go through with treatment, anything that any doctor gives you. You have the right to encourage and obtain from physicians and other direct caregivers relevant, current, and understandable information concerning diagnosis, treatment, and prognosis, like I was just talking about. And you have a right to privacy. You have a right to receive any documents from the doctor's office. If you don't receive them, you please ask. Don't be afraid to ask. It's your right to have everything that you need. Those are just a few that are on that list. It's a whole document. So I'm sure we'll be able to post that on the website.
Yeah, great. Thanks, Serena. I think all of those are really important, and a lot bring me back to kind of previous conversations that we've had about communication and health literacy and how to really advocate for yourself to make sure that you're getting the care that you need. So yes, great tips, and hopefully we can post them so everybody can reference back to them. So Dr. Rao and Maryanne, I wanted to ask from your perspective, again, if a patient comes to you and they say their medication's not working, what information is most helpful to you to try to figure out what needs to be adjusted or what changes can be made, to try to find something that works well for them?
Yeah, and I'm not making this up. I literally had about a 2-hour conversation yesterday with the patient with this exact same question. She had been on a certain type of insulin and she wasn't seeing the effects that she wanted to, and so I think it's important I think number one, the patient should always bring it up, and I think that's the first step. And then I think, you hope that the provider is going to sort of delve into why, so why do you think it's not working? And I think, as I think important for the patient to bring it up. And I think when you kind of dig deeper, a lot of times it's somewhat of expectations, sort of thinking that this was going to work overnight or within 2 days. And I think that's an important thing when you're starting medications, to ask your provider sort of what are your expectations for this? When will my sugar start getting better? Many of these medicines, when they were first brought onto the market, went through clinical trials where in those trials, many of the patients had touch points, or study participants had touch points like every week, and sometimes we forget about that in the clinical setting, and we just say, okay, start this medicine, see you later, we'll see you back in 3 months, and then the patient's wondering, wait a minute, there's some adjustment or titration. So I think one is, first is always, there's a chance that medicine's not working for you, and that there needs to be a different choice, or something has changed. For example, we always get worried about misdiagnosing a type 2 or type 1 in the wrong direction, and then we're using pills for a person who just needs insulin. That's one example. But I think that, on the other side, a lot of times it's probably because we haven't set up like, oh, well, in a couple of weeks, this is what you're going to notice, and here's when you need to touch base with us again via phone, and then we're going to titrate up or sort of keep you at the same dose, is kind of how I think about it, is my approach.
Yeah, I think working along with, physicians, a couple of things from, my role come up. First thing, when I'll sit with a patient, I usually ask them when they're having these problems, can you tell me about your day? And then I'll actually sit down with a paper and a pen, and, what time do you get up? Then what do you do? When do you check your blood glucose? When do you eat breakfast? What time do you eat lunch? What do you usually eat? And we'll go through the entire day, talk about sleeping, everything else. The other thing is, sometimes when I do that, tell me about your day, sometimes I'll also find that patients are trying to work for their medication rather than letting their medication work for them. So they'll get stuck into just exactly what Dr. Rao said. They're expecting this medication to work in a certain way. When it doesn't seem to be working for them, then, okay, I'm getting some low blood sugars, so I know I'm going to eat even though I'm not hungry. And then they get themselves into more of a problem because they're trying to work for a medication rather than, letting it do its own work. And that's not a good place to be. That's a time to call your healthcare providers. And then, just again, finding somebody in my type of profession, we're called Certified Diabetes Care and Education Specialist. We used to be known as Certified Diabetes Educators, or CDEs. You might hear that term. And we're out there, and there's thousands of us across the nation. And if you can find someone like myself, and certainly then go forward with someone like Serena and the peer support, where people can have good information and good conversation, you can find out a little bit more so that you can make that next move and reach out to your physician. But you're absolutely right. It is a really good idea as clinicians to tell the patients to check in again with me. If I'm not reaching out to you, feel free to check in with me. I know my mom, who has type 2 diabetes, and she's in her 80s, and she's of the mindset, well, I don't really feel that well. I'm trying to work with this medication, but gosh, I'm going to see my doctor in 3 weeks. So I'm just going to wait until I see my doctor. I don't want to call their office. I don't want to bother my doctor. They're busy, and they probably don't want to hear from me. So I'm going to put that back to Dr. Rao. And how do you feel about patients, calling the offices? Is that something that, is okay?
Yeah, I mean, I think this bothering concept comes up a lot, and I think we forget how, as providers, sometimes we forget how patients think that the interface is only supposed to happen at the in-person visit, and I think that's why it's important, again, for the patient to ask, would it be fine? I would love to call you within 3 weeks if this is not working. How does that sound? And sometimes, like Maryanne was mentioning, there's a nice setup where there's a great collaboration between the CDCES and the providers, where that adjustment can happen, even with interfaces with the diabetes educators, sort of under sort of collaboration with the doctor. So I think that absolutely, I think it's great for you to make an effort to reach out to your provider. And then now, again, not to berate sort of the technology aspect, but a lot of patients now have access to portals where some of this can be easily done in the form of a message to the provider team, which again includes not only the physician or nurse practitioner, but the rest of the team who can easily make these adjustments. And you don't have to wait again until that 3 or 4 weeks, because then you're losing sort of some time there, I think, and where a meaningful change could have been done. I was going to ask Maryanne, have you ever had a scenario? I recently had a patient where they just weren't taking the medication properly, where I realized that they weren't sort of capping their insulin pen with the needle and just sort of squirting the insulin on their stomach and expecting that it went in and it goes in,
Sorry to laugh, but yeah, I teach nurses also. I have about 50 nurses I teach. And so I tell them all the time to please review insulin injecting technique with patients, even if they've been on insulin for a long time, because if you can imagine it, it can happen. And, and I'm not laughing at anyone. I'm just kind of amazed that because of the complexity of having to take insulin, and even though we make products that we think are very simple to use, if we as clinicians, we as educators do not educate properly, then things can be easily done improperly and can happen. And so, one of the things that's been out there in our diabetes world among clinicians is that insulin pens, for example, they actually have two caps. They have a clear outer cap on the pen needle. So the pen needle has a clear outer cap, and then it has a different color inner cap. And it can either be like green, pink, white, or yellow. It's just depending on the size and the length of the needle. And so we've had a lot of discussion over the past years where patients take off the clear cap and they leave this inner colored cap on, and they say, well, that injection didn't hurt at all. Well, it's because the needle never went inside the skin. You just actually just place the cap next to your skin. And then when you push down on the plunger for the insulin pen, you actually didn't have any delivered. I also had a situation where, unfortunately, I had a patient who was new to an insulin pen, and this is on me. This was my fault. I didn't explain it to him properly. But what happened is he came back after about 2 weeks and he said, this insulin pen is great. I'm never running out of insulin. It's going to last a really long time. And he said, and so that's really wonderful. But he said, my blood sugars, they're really, really bad. And I said, well, okay, well, let's look at how you're taking your insulin. So he had brought his pen along with him, and it happened to be time for his injection. So what he did is he took off the outer cap. He took off the inner cap, and he had dialed his insulin pen up to the number 2, which is what we call an air shot. I tell them it's to clear the needle and make sure your needle is working. And he did that. That worked. And then he dialed it up to what his dosage was. He cleaned off the site. He injected the pen into the skin. He pushed the needle into the skin. And then he dialed the pen back to 0. And then so he never got any insulin. And so, it was going to last forever because he really wasn't taking any. But, it was on me. It was totally on me, because when I was trying to explain to him how to do this air shot, I guess I made it too complicated and he just didn't understand. And so we went back over it again. And then, of course, I did call him, the next day and kept in very close contact with him. And then everything was working fine. But, clinicians have to remember that, we have to be clear and take the time and actually maybe not even just explain it one time. Maybe with some patients, we have to go over it 2 or 3 times during that same appointment, just to make sure that we're not, miscommunicating. But, it can happen. If you can imagine it, it can happen.
I mean, the insulin instructions is a time I spend a lot of time on that. And, especially with these, you have, both rapid acting insulins, things that work quickly and sort of your long acting insulins and when to take them. Right. And I think sometimes we just say, oh, take with meals, and the patient may not understand that, you need to have the meal in front of you, you need to have checked your sugar, and then, sort of 5 to 15 minutes later, start your meal. And that's not just because we sort of make that up. That's sort of how the insulin enters your system and is able to attack that meal, which is going to cause a surge in your sugars. But hopefully, if you take it the right way, then that insulin can do its benefit for you.
Yeah, Dr. Rao, thanks for that. And thank you for, I think you preemptively responded to one of the questions that we have from Joy on Facebook, which is about insulin timing and how it can be adjusted to work more efficiently. So I think you just gave some great examples. Anything else about timing of taking your medication and how you can kind of time it so that it works best for you?
I think, the one thing that I hear a lot about is this, the usage of some of the longer acting insulins at bedtime. And, sometimes people just fall asleep and they forget to take it, and so sometimes I try to maybe set a fixed time, say like 9 or 10, so that you're going to get it, every day. Because I think one thing we get into trouble with is, if you miss a couple of those injections, then it's hard for us to assess, if you're getting enough or the proper amount, or the proper sort of brand or type of insulin. And then, of course, with the rapid acting insulins, again, the whole concept is that those should be kind of connected with the food that you're about to eat, those being the meals, ideally.
Yeah, and we actually have another comment in the chat from Aunt Shelia from Facebook that says, I'm still having problems understanding insulin and eating. And it sounds like there are just a lot of factors in terms of the type of insulin that you're taking or medication and what you're eating. So any other comments there or any tips for helping patients understand that very complex
Yeah.
formula?
I think Dr. Rao brought up a really good point. I had a patient years ago who kept going low at breakfast time because she was doing what Dr. Rao just alluded to about making sure that your meal is ready. So she'd get up early in the morning, she'd check her blood glucose, then she'd go ahead and take her insulin, and then she would start to try to prepare breakfast. Well, she was making a pretty elaborate breakfast, and it was taking more than 15 minutes to make this breakfast. And so while she was trying to make it, she'd suffer low blood sugars. So, I think, I don't know if Serena sees that a lot in her peer support, but, that's what sometimes people don't understand. They, can't take the insulin and then just decide to start to make, a big meal.
Right. And actually what I see a lot more of is, well, what if I forgot? So do I double up on my insulin? Like, say if someone forgot to take the breakfast one, do they double up at lunch, or do they just not take it and just take a regular one at lunch? Or how does that go, Dr. Rao?
Yeah, these are where you, again, speaking with your provider, getting a good insulin instruction plan is important. I mean, I usually tell, if you skip the dose, definitely you're not doubling up at the next one. I think it's just you're gonna notice your sugar probably being a little bit higher at the next point because you missed that round. Sometimes some of us provide some correction doses that help with the adjustment based on what your pre-meal blood sugar is. But I think just never double up. I think just take the next scheduled dose that you're supposed to take, I think is the best approach, but expecting that it's going to be a little bit higher because you missed that that first dose. And again, these are the things that I tell my patients, try to write down these notes as they're happening, right? Because these are the type of things that you can definitely interface when you get in front of your physician or the educator or other provider, because this is what you need help with, right? Because you're all alone and you've got to make this decision on your own. And that's we understand how challenging that can be.
Dr. Rao, can you speak a little bit about, because of the insulin timing, stacking insulin? So like, how far apart should meals be if you're taking like a rapid acting insulin? Because a lot of times I have patients, and a lot of times it's people who are even newly retired and they have that luxury of not having a schedule, and they think that's great. And I guess we all think that would be great, but I keep telling them the body likes to be on a schedule. And especially if you're taking certain medications, you really do need to stay on a schedule. But I'll have patients who will say, well, I just wake up maybe around 10 o'clock in the morning, and then I take my insulin and my breakfast. And then, I kind of want to have a little early lunch. Maybe I'm going to meet somebody and have lunch, and then we're going to have lunch at 11 o'clock. And then, boy, by the time the afternoon comes, my sugar is really, really low. So can you maybe speak on that a little bit for us?
Yeah, I think we were all excited when the sort of the rapid acting types became available, as opposed to sort of the historical short acting or regular insulin, which again, both of them may be prescribed by your providers for sort of attacking the meals. I think you'd like to see a good 4 to 6 hour separation in an ideal scenario. I think that between the meals is what I'm alluding to. I think that there's a bunch of factors that go into sort of figuring out how much dose you're supposed to be getting, and including your kidney function, your liver function, et cetera. But I think the key aspect here is these are the type of things you want to bring up to your provider, because perhaps in that scenario you take an amount at lunch, but it's a lot lower. Because the issue becomes is that, as you're talking about the stacking concept, there's this aspect that, perhaps, as you take these multiple doses in such short period of time, all of that insulin might work at one point, and then you have a tremendous low blood sugar episode, which you don't want to have. And I think here this is where monitoring can be crucial, sort of before and after meals. But bring that up to I encourage patients to bring that up to your provider, because they may not know. They may be thinking, oh, you're having meals in a set way, and then you find out, oh, actually they get up at noon, and they don't actually have 3 meals, and that's important.
Right. Dr. Rao, could you also speak a little bit about sensors, glucose sensors, because I don't know if Serena's seeing a lot of that in peer support. People are all asking about it, but that seems to be a really hot topic among my patients.
Yeah, I think we're really excited that there's a lot of options now for what we call I guess continuous glucose monitors or CGMs or sensors. So these are devices that can be placed on your body in a variety of ways, and obviously we teach the patients to place them on their body themselves. Anywhere from 10 to 14 days they stay on, and they measure. The benefit is they're measuring your sugars continuously. And so, you can constantly be checking your sugar, and you don't have to prick yourself. And this can be great for what we just brought up, sort of seeing what's going on with your body before and after a meal, before and after an insulin injection, middle of the night, early morning. And I think we're really excited that there's a lot of options now for our patients. And many of the insurance providers are really helping folks to get coverage, because it seems like it's really helping people achieve their goals for their diabetes control. So that's, I think, the most exciting part. And then most importantly is you get the patients coming back to you saying, oh, Dr. Rao, that's why you told me not to eat that, right? Because they can, so, I just have to bash my head, but it's great. It's great. It's the feedback is a wonderful human concept, right? So that I may be saying, oh, this food is going to do this to your sugar, but until you see it, it's picture's worth 1,000 words, right? It's just amazing. I think one other point I just want to make is that these sensors do measure sort of they're not technically measuring your blood glucose. They're measuring a fluid that's right around that blood vessel. So it's measuring the value of that fluid, but it kind of connects fairly well with blood glucose measurements. But for some of these devices, they do mention that if at any point you don't think that number jives with the way you're feeling, you do have to check a blood glucose, and that is important to remember. But some of the devices don't even require that because they're calibrated so well. And it's really exciting for us to look at the numbers.
Yeah, that's great. And we have another question from Facebook, just about, whether a specific medication is rapid acting insulin or not. And so, to generalize, how I know patients can be on multiple medications, their medication can change. What are your recommendations for patients so they really understand what they're taking, what type of medication it is, what it's doing for them, and kind of have that full understanding of what could be a really complex medication regimen?
Yeah, I mean, I think I think it's important to ask your providers, what does this medicine do? Why am I taking why am I taking these types of insulins? Um, you know, I think that's the most important thing, is what I would say. And then, there's a variety of brands for these rapid acting insulins that you can ask your provider and say, hey, I'm on this. What type of insulin is this? Can you tell me, is it a short acting or rapid acting or long acting? And then, the other thing is, I think we forget about this. We talked about them earlier. In the show, is the pharmacist. The pharmacist can really help with this, and they can help label and identify each medication, and so that you understand what types of insulins you're on, if it's insulin injections or even any of your other medications.
Yeah, Dr. Rao, I think also if you could please just say a little bit about U500 regular insulin and what that is, and what is this U100, U200, U500? What does that mean?
Yeah, so the standard insulins that we most insulins are this sort of concentration or strength of what we call U100. And I think when you think about U500, it's basically sort of 5 times sort of concentrated. So you're not one of the concerns we get with higher doses of insulin, meaning higher units of insulin, is that with the U100, a lot of volume, a lot of liquid has to be injected into your body. And so then we get concerned, is your body actually getting that full injection when it's that large of a volume? And so the U500 is a more concentrated form. So you're still getting the same amount of insulin strength, but it's in a lower volume. So the assumption is it's going to absorb better and help your sugar control a little bit better. There's U500 types of insulin, which was brought up as a question, and can be used multiple times a day. There's a U200, which again is 2 times the sort of the concentration. So again, I think this gets around this concept of, we were always wondering when we sort of get, I mean, we would love to be able to not get patients up to that dose, but sometimes patients need that dose. And if that's the case, those high doses, we're always worried, is that high dose getting into their body if it's the U100 form? And these newer U200, U500 forms sort of get around that concept, hopefully.
Right. Yeah. And the U500 is, at least in my world, when I see it with patients, is usually reserved for patients that are taking very, very high dosages of insulin. So if you're not taking very, very high dosages of insulin, this probably wouldn't be something your physician would recommend.
Yeah.
And Serena, I want to ask you to jump into, in terms of the role that that peer support can play in helping people understand their medications. And do you field a lot of questions around medications with the people that you're working with?
Yes, I was waiting to make this example, but y'all, I have a real true story. Check this out. Okay, so Thursday, we had our virtual peer support meeting on Thursday, and it was a young lady that was there, and she said, yeah, I've been diagnosed with pre-diabetes. And so I asked her, I said, okay, so how are your sugars running? She's like, I don't know. And I'm like, okay, why don't you know? I said, do you have a monitor? And she's like, yeah, I have one. The doctor prescribed me one. I got him everything, the test strips. I said, so why haven't you been testing? She said, well, I'm just terrified of needles. I've had it for 3 weeks. And then I was like, okay. I said, okay, so let's find out how. I said, did you ask the pharmacist how to take it? And she's like, well, no, they just gave it to me and they just said to check my blood sugar. And I'm like, without any knowledge. This is why education is so important. So I proceeded to get on there and I showed her, I took mine on camera and I showed her every step. This is the test strip, this is where you put it, all this other stuff. So yeah, we show people, like, well, I do. I actually show people on camera, which I can because I am actually dealing with diabetes myself. So these are things that I do on a regular basis. And so when it comes to medications, I definitely lead them to their pharmacists and their physicians, because I have some knowledge on medications, but I'm not qualified to speak on medications. So I don't want to give somebody the wrong information and they come back and like, oh, I'm suing you because you gave me the wrong information. Oh man, but yeah, so yeah, we get that a lot, Susan, and peer support medication questions all the time.
Yeah,
but you're so right, Serena. I mean, I think one of the healthcare providers on the person's healthcare team that gets forgotten most often is that pharmacist. And that pharmacist is so easily accessible usually to people if they have a local pharmacy. You know, they've got long hours, they're there, and you can even go through the drive-through. But, you know, definitely don't forget that pharmacist. They are a wealth of knowledge. And I don't think people maybe understand that, you know, as you can see from my name here, so I'm a certified diabetes care and education specialist, and we are an interprofessional specialty. So to get this certification, you have to be either a nurse, you can be a dietitian, you can be a physician, but you can also be a pharmacist. And so, you know, there's a lot of pharmacists that are out there that are also certified in diabetes, and they're just a wealth of knowledge. So please don't forget to talk to your pharmacist, because they can show you how to use that glucose meter. And then, you know, sometimes even myself in teaching patients, you know, if they had a meter that it was one that, you know, is a newer brand that I hadn't seen before or something, we'll just turn it over. We'll call the 1-800 number on the back of the machine, and you can get often live support and help. And if not, you can go to that website, and they often have the videos even right there on the website that will show you how to use them. So, you know, that's great information that you gave them and that you helped them, Serena. But, you know, we could just look to these other resources too. There's a lot of information out there. It's a good point.
Yeah, thanks, Maryanne. I think that's a great point about kind of engaging the entire care team that's available to a person with diabetes to assist with, you know, not just medication management, but with self-care and generally. Yeah. And Serena, coming back to a point that you made, you know, I just want to acknowledge kind of, you know, for people who are living with diabetes, when you have to take your blood sugar, you have to take these medications that you might need to inject, like that's really hard to do. Like nobody wants to do that. And so, you know, I think it really is a victory to know how to do that, to be able to do it, to be tracking that, to stay on your medication every day. And, you know, I think it's worth acknowledging those victories and those accomplishments, right?
Yes, definitely.
Mm-hmm.
It's amazing. So much that they have to do on their own. I think it's great that they're able to do it, and the achievements that they can get when they do it right. You know, so it's really exciting.
Yeah.
Emphasis on doing it right.
Yeah, an emphasis on like that education and that teaching, right? And as we've been talking about it, you know, I think each of you in your roles, you know, as a diabetes educator, as peer support, as a physician, you know, you each play a role in that education and that teaching and that empowerment of patients, so they know, you know, how to take care of themselves and can do that. So I have a specific question for you, Dr. Rao, and that's just around sort of when someone should seek a specialist. So again, coming back to this idea of the care team, you know, there might be lots of different people, different physicians involved in your care. You might first get your diagnosis through a primary care physician. You know, what are some considerations for patients that think that maybe they might need a different level of care or need to see a specialist for the first time?
Yeah, I mean, I think, I personally, I mean, obviously I'm slightly biased. I'm an endocrinologist, so, but I think that if I personally think if somebody feels that they want to see a specialist, they should have every right to, you know, to see a specialist. It's just, you know, and I think, but it's important to, you know, obviously, some of these things are predicated by your health insurance, et cetera. But I think that, you know, any primary care is always supportive. If somebody, if they're saying, oh, do you mind if I, you know, I would love to just seek out and see an endocrinologist, you know, once or twice and just, you know, get a different take or you know, a better understanding of what's going on. There's nothing, I don't think there's anything wrong with advocating for oneself and seeking a specialist. I think I'll be honest, be very concerned if a primary care is saying, no, I don't want you to go see somebody. I think that is, that maybe was the way we did things in the past, but I think now, this is a shared decision making and sort of we should be doing this in a collaborative nature. I think that. I think that would be my simple answer to that. I think that many people with type 1 diabetes, who are seeking some interest in devices and other aspects of care, is nice for them to touch base with an endocrinologist. I think would be great. But I do also know that, we're not available everywhere, and many primary cares do pump and sensor therapy wonderfully, so I think, and with the team approach with the same folks that we're, talking about today. So I think the answer really is if somebody feels like they need to see a specialist, they can. And then the great thing is you can either say, oh, thanks, that's great. That's exactly what my primary care said, and I'm on a good track, or, oh, no, I'm not, and here are some aspects, and it's a team approach, is how I think about it.
Yeah, that's great. Thanks. Any other tips from the rest of our panel around how to really foster that team-based approach to making decisions and to taking care of yourself and doing that shared decision making?
I'm just going to say you definitely need to access education. Like Maryanne was talking about all through the broadcast, the certified diabetes educators specialists, they have a wealth of information that you can draw from. Even if, I hate to say, if you don't feel comfortable talking with your doctor, you really shouldn't have the doctor. You need to find one you feel comfortable talking to. But there are other places there you can draw education from. Education is so important because when you don't know, it's kind of hard to do for yourself when you're depending on every 3 months physical, every time you go to the doctor. If you go, that's the only time you get to ask questions. And it's really good to draw from different your care team of specialists to get all the wealth of information that you need to have.
I think we each have our own unique perspective, which is why, it is a collaborative care, so that's why it's so important to pull in all these different members, of the care team. And the other thing in regards to education, whether right now it's done virtually online, a lot of diabetes education may be, going that way. We used to have classes, of course, but with the current, healthcare pandemic situation, a lot of this stuff is now having to be done one-on-one virtually. Although I will say that there's a new process that's going to start here in the Houston area where they're going to try to do online classes. So it's going to be like a Zoom with online classes, and they're supposed to start in September. So we're excited to see how that's going to work. But, a lot of times with these classes, or if you're going to see a diabetes educator, you can bring your family members with you. And a lot of people don't realize that you can do that. And even if you're getting this covered by insurance, bringing that family member along with you isn't going to cause additional charge. It's usually free of charge to bring at least one family member with you to diabetes education. And I think we've had this conversation on, previous video casts here, but, bringing a person with you to either diabetes education or to even to your healthcare visit with your physician is a good idea, because they can go ahead and they can, help you remember questions that you might forget to ask.
Mm-hmm.
Yeah, absolutely. I think that's a great point, Maryanne, about how your care team it's your providers, right? It's your pharmacist, your physician, your educator, your peer support, but it's also your friends and your family members and anyone else who's familiar with you and your personal situation and what you're going through. So any other tips for how to, bring in caregivers and family and friends and kind of have them as support along your journey?
I would say find someone who's not gonna be easy with you, because the easygoing ones are just like, oh, whatever you want to do, whatever. No, you need the ones that are gonna be like, So are you really like not going to check your blood sugar? They like, have you checked it? You know, and not really be on you like that to, you know, try to kind of burden you and smother you, not that, but sort of like to bring some sort of accountability, because accountability does help. Then you won't feel like you're by yourself or you're alone in managing your diabetes. It helps to have support, and especially support of those who you live with or people that you see on a regular basis. It could be a coworker, it could be a friend, it could be someone you see at work, you know, just someone that's gonna really like not cut you any slack is important. That's what I'm gonna say.
So Serena, being a person living with diabetes, was it scary when you first learned that you had diabetes and that it was a self-managed disease? Was that scary to hear that?
I had so many emotions when I found out. I was in the ER when I found out, and my experience is so weird, y'all. When I was first diagnosed, I was misdiagnosed as a type 1. So I think it was because of my age. I didn't find out until 5 years later that I was a type 2. So I was being treated as a type 1, always having hypoglycemia in the ER all the time. And then we figured it out. She's a type 2. So things have been scary. And when they were like, when I was in the hospital, when I found out I had diabetes, and they said, okay, the nurse comes in with a needle and she's like, you're going to do this yourself. Let me show you how to do it. And I'm like, what? No, I'm not taking that. Are you serious? Like, no, can't you do it? That's what you get paid to do. Can you do it? And she's like, no, you got to know how to do it, because we got to, we got to prescribe you some insulin. You got to know how to do it. I'm like, oh my goodness. Yeah, that was a really trippy time for me, but I made it through here today.
Yes, you did. Now you're teaching others. So that's great.
Right.
My daughter has type 1 diabetes. She was diagnosed when she was 10 years old. So, I don't know if it was a good thing or a bad thing that I was already and had been a nurse for many years before she was diagnosed. So, I was quite comfortable with, how to give insulin, of course, and all of that. But, she wasn't feeling well. We weren't sure exactly what was wrong with her. So, of course, being a nurse, I looked through all my, pediatric textbooks and stuff like that. And I had thought that it could be, something else, or it could be type 1 diabetes. And so we went to the pediatrician, and I had a little conversation with my daughter before we went, and, she got her lab work done, and we're sitting in the pediatrician's office, and he comes in and he says, well, we found out what's wrong. And he said, it's type 1 diabetes. And I blurred out, oh, that's wonderful. And my daughter looks at me like, what is wrong with you, mother? I have a disease and you think it's wonderful. And I said, well, you don't understand. This is something you can live with. This is something that, we're going to manage, and you're going to live well, and you're going to have a, full and wonderful life. And you can live with this. But, she goes, you said it was wonderful. What is wrong with you? But that was my perspective on it. But I have to say something just a little bit, because, I'm a proud mama. But, so, as she looked at it then from that perspective, and we went through, and of course, I began working in the field as a diabetes educator, and she grew up in that world. She is now also a certified diabetes care and education specialist. And she's actually an insulin pump specialist. So I'm very, very proud of her. Yeah.
That's
she
great.
did great. She's helping others. Yeah.
Yeah. Thank you both for sharing kind of those stories and your personal journeys. I feel like, it's just more evidence that this is a journey for everybody who's on it, right? It's not like you figure out the one thing you have to do and then you do that forever. Things change. And as we talked about today, having that clear communication with your providers, having that support network, that's all really critical for being able to adjust and to move forward and to figure out what works and to take care of yourself and stay healthy. So we are coming very close to the end of our time here today. So I just want to ask our panel if anyone has any final words of wisdom for all of our viewers today.
Keep trucking along. Give yourself a pat on the back sometimes, because you're probably doing a greater job than you're giving yourself credit for. So I think that's really important always.
Yes, and I would say your perspective of everything matters. Exactly what Maryanne was saying. When you come in with a good perspective and a good handle on what's going on, and you ask questions, always ask questions. Be a person who asks questions all the time, and when you do that, you can manage your diabetes more effectively.
Yeah. And don't wait to reach out to your healthcare providers. You're not bothering them. They would much rather have you reach out and say, hey, something doesn't seem to be working well for me right now, rather than waiting until it gets to the point where it's, really more critical. So you're not bothering healthcare professionals. We actually love when you reach out and tell us what's going on.
Well, thank you all very much for joining us this morning. It's been a great start to our weekend with yet another talented panel of guest speakers. So to our viewers, we hope that this conversation has made you think about your medications in a different way and given you some key takeaways that can help empower you to talk about your medications with your care team and your friends and family. Continued gratitude to our friends and colleagues who took the time to share this morning. And everyone mark your calendars. We'll be broadcasting again every Saturday, 10 a.m. Central Time, 11 a.m. Eastern Time. And our next episode will air next Saturday, September 5th, where our panelists will discuss disaster preparedness, including groups and programs who have and will be helping those who need this as their communities begin recovery. Keeping in mind, in particularly the Gulf and East Coast that have hurricane season that lasts until November, wildfires that are currently happening in California, and everything else that will be thrown at us this year. So thank you, everyone. Thank you for being part of the My Diabetes HQ community, and we will see you next time.